Okay, so the topic that I'm going to deliver today is on implant rehabilitation, surgical and restorative treatment planning from a prosthodontics point of view. I have actually chosen myself because Dr. Fidaus gave me the chance to choose whatever topic you want to talk about. So this is the topic that I want to talk about. And one of the reasons why I have chosen this topic is so I can actually express and demonstrate some of the photographs that I have been taken, undertaken while I was training at Eastman Dental Institute. Okay, so the topic that I'm going to deliver today is on implant rehabilitation, surgical and restorative treatment planning from a prosthodontics point of view. Okay? Right, so here is some of the outlines. Basically, before we start on any implant cases or even any of the restorative cases or any of the dental treatment, we have to go through the history examination, special investigations and diagnosis. And with that steps, then you move on to do what we call a stabilization phase. So I will go through with you what stabilization phase means, and then there will be another stage called jaw registration and articulated study cast, and diagnostic phase, a bit of a treatment planning, and then some talk about surgical phase and restorative phase, and then finally with the maintenance phase. So this is the outline that I have that I'd like to go through with you. Okay, so why I am standing here? So I just want to actually just give a brief overview of what prosthodontic specialty is, and so that will justify my presence here in the workshop, which is a specialty that relates to the diagnosis, treatment planning, rehabilitation, and maintenance of the oral function, comfort, appearance, and health of patients with clinical conditions associated with missing teeth and deficient teeth, including maxillofacial tissues using biocompatible substitutes by means of fixed removable implants and maxillofacial prostheses. And this has been taken from the ADA, American Dental Association. So now, coming back to the actual title that I have chosen, implant rehabilitation. So what is it actually? So this is an example of a full mouth rehabilitation in a complex crowns and bridge work, and this is a patient who has had basically a generalized tooth wear necessitating a full mouth rehabilitation. So as you can see, this is a full mouth reconstruction done by one of my colleagues at Eastman Prosthodontics. So what he has done was providing upper right 3 to 3 with composite build-up, and 4 and 6, and the other side 4 and 6 with a PFM crowns. Okay, and then looking at the bottom arch, I think the patient also had a generalized tooth wear, reducing the vertical dimension. So the full mouth rehabilitation takes place involving an increase in vertical dimension constructed in a reorganized occlusal manner. So as you can see, you can have a couple of gold crowns at the back teeth, PFMs, and lower composite build-up. Okay, so if we want to convert that into implant rehabilitation, we would view using the same concept. We are managing the patient's occlusion. We are actually rehabilitating patients' missing teeth. We are actually providing a new or conform the patient's occlusal surfaces, which I will begin talking a bit more later. And this is my case, which is slightly more conservative as compared to my colleagues, which have a lot of conventional preps. As we are nowadays moving more towards conservative and more aesthetics. This also patient who has had a generalized tooth wear of upper and lower arch, and the patient has had a history of acid reflux for many years, and also a heavy intake of diet cokes. And therefore, what we have provided is a full mouth reconstruction with upper 3 to 3 palatal gold backings with a composite build-up, 4-5 on the upper arch with direct composite build-up. The lower is a 2 to 2 composite PFMs on the lower canines, composite build-up on the 4-5s, and gold onlays on the 6s. Okay, I think one of my colleagues here, we have been trained together in Eastman, Dr. Nazar, she has also carried out similar full mouth reconstruction, but in the children. So I think prosthodontics is more working in the adults. Okay, so this is another example of another full mouth reconstructions involving a fixed and removable prosthesis in order to manage patient's occlusion, replacing the missing teeth. So basically, prosthodontics, we are looking into rehabilitation of the patient's missing teeth and reconstructing the occlusal surfaces. So that includes either with fixed prosthesis, removable prosthesis, or implants. Okay, now I have looked at the glossary of prosthodontic terms in 2005. The definition of implant rehabilitation is restoration of the form and function of the masticatory apparatus to as near as possible via dental implants, either with single, partial, or full arch. As you can see, when we try to build up the occlusal surfaces, we try as much as possible to maintain all the occlusal anatomy, the fossa, marginal ridges, and the fissure patterns. And in order to also making sure that the patients feel comfortable and the occlusal is in harmonious with the rest of the dentition. Okay, this is another case, full mask occlusal rehabilitation with combined crowns and bridge work, and also dental implants. As you can see, there are some implants on the upper left region that to replace the missing 4, 5, and 6. But at the same time, the patient needs some kind of form of rehabilitation or reconstruction treatment. And usually these patients, they are the tooth wear cases. They are patients who have a severe or generalized tooth wear, patients with missing teeth, for example, hypodontia, amylogenesis imperfecta, dentinogenesis, and patients with failed dentition. These are all the patients that require reconstruction. Okay. Now, the aim of the implant treatment is to provide replacement of the missing teeth and occlusal rehabilitation by means of dental implants, either in a conformative or reorganized occlusal approach. So, for example, a patient who requires an occlusal filling, yeah. So you may not want to build up the amalgam high, so that the patient won't have a high bite. So you are actually conforming to the patient's occlusion, so that the patient will feel comfortable. And that is what we call conformative. As you have seen in the photograph I have shown previously in the previous slides, they are the reorganized nature. They are very complex cases that involve 2 to 3 years treatment. While I was in ISMO, we spent 2 to 3 years restoring all these cases. But in the private setting, it can be shortened down because of better facilities or close monitoring of the patient. So the duration can be shortened down to at least a year or a year and a half. But the reason why we want to restore with the implant is to replace missing teeth, to restore the occlusion, so that the ideal occlusion will contribute to the greater success of the restoration. So if we actually pay more attention to the occlusion, we are actually trying to maintain the success and the survival of our restorations, including the dental implants. So that is my introduction, why I want to talk about from implant rehabilitation point of view. Okay, now looking at the patient assessment, as you're all aware, we are all clinicians. We have seen a lot of patients. We need to consider one of the most important things is the expectation, patient expectation. We have to evaluate the patient's needs and demands. If the patient have a high expectation, then the clinical skills involved will be high as well. So we have to be clinically prepared in order to restore, for example, a single missing tooth who demands a very highly aesthetic case. And also the financial cost and time. If the patient doesn't have, if the patient doesn't have too much money at their disposal, then you may want to consider a lot of other factors in your treatment planning. Okay, so you also have to find and to outline the reasons for tooth loss. Patients who have caries as a result of their tooth loss, periodontal disease, you have to in fact see whether is the existing disease is still remain, or whether you have to eliminate the disease, do the stabilization phase, control, eliminate all the caries that the patient have. And basically there's no point planning, restoring or placing a complex implant within bridgework, whereas there is a big caries on the upper right central incisor. That's, for example, that's what I meant. So you have to treat in a more holistic approach or more holistic manner. So medical history, you have to make sure that there are no medical problems that is contraindications to surgical. One of the most important things is, for example, bleeding disorder, patients undergoing radiotherapy to the head and neck that will actually impart or prevent the healing potentials. So if you put an implant, there could be, osteoradionecrosis or the avascularity of the blood supply of the bone. So you have to be careful with some of the medical conditions. And the other things that has been quoted mostly on the papers in periodontology and some of the, some in the dental articles is about the smoking. If the patient's on heavy smoking and also uncontrolled diabetes, you have to be careful. If the patient is on controlled diabetes, on medications or diet, having diabetes, then that is something that you can consider. Okay, examinations. So this is to identify any dental problems or any dental disease and to establish the ideal oral health status back to normal. So if the patient has a deep caries lesion, so you want to address that under the stabilization phase. If the patient has a chronic gingival chronic periodontitis, you want to address that. You want to liaise with periodontitis, manage all these gum disease until the patient has reached stabilized maintenance phase. Then you want to consider the implants. Okay, the other thing is you also have to evaluate the space for a dental implant. Whether is it adequate to have a dental implant, what size of the implant, what length, and how much bone quantity and quality. The nature, thickness of condition of soft tissues, for example, if the patient has thick keratinized gingival tissue, so you have a better control of the gingival tissues. If the soft tissue is of a thin keratinized type, then you have more challenging because the tissue may more likely to relapse or have some kind of a gingival recession. So you may not want to have a dental implant at the same time showing a bit of a neck at the crown of the tooth. So these are something that we as a prosthodontist consider in our treatment planning. Then whether the case is restored in a conformative or reorganized occlusal approach is something that you have to ask regularly. You will see a lot of patients requesting multiple implants or multiple crown and bridge work, whether you restore in a conformative or occlusal, reorganized occlusal approach. The complete dentures patients, for example, they are a type of reorganized occlusal approach that we are mostly feel that I haven't done or haven't have the idea what reorganized occlusal approach is. The complete denture patients, they are an example of a simple reorganized patient. Okay, now I'm just going through a bit more of some slide and then I can show you some of the photograph. But we must not forget about the investigation. For example, the use of OPG, periapical radiograph, CBCT scans, Canova, which is a spirotomogram, CBCT scans. And don't forget the study models which have been articulated on the articulator, and do all the appropriate measures such as full perio charting and determine the prognosis of disease. Okay? So this is an example of a radiographic stent. As you have taken the cone beam CT scan, you use a radiographic stent which have made of a combination with barium sulfate and cold cure acrylic resin. So you try to actually fit in the patient's mouth and take it with the cone beam CT scan. So it will show as a radio opaque in the radiograph. Then you can plan where you want to put your implant. So basically, from prosthodontics point of view, it's all about planning, and then from the planning you deliver to the final restorations. So it's a lot of planning, and then comes to the surgical and restoration phase. So this is an example of radiographic stent of the upper and lower arch. This is an example of a cone beam CT scan of the. Basically, we are considering the mandibles. At this stage, you can see more mandible than the maxilla. So you can see the radio opacities on as determined by the radiographic stent. So you know exactly where you want to put the implants, whether or not there is a bone concavities on the labial aspect of it, whether you want to avoid that or you want to do some kind of bone augmentation, how long is the implant, what is the width of the implant. It's all determined from your diagnostic wax-up. So if you have a diagnostic wax-up done, you show your patients, you try to do a mock-up on the patients, try in, then the patients will be able to see what the result, the final result is like, then you try to deliver according to what you plan. Okay, so this is a bit of an architecture work or engineering bits and pieces. So you plan things and then you deliver the final towards the end, according to what you have planned.